Okay, so hello everybody. Welcome back to the channel. I am delighted and very privileged this afternoon to be joined by Ms Aimee Charnell, who is a surgical registrar in general surgery, currently completing her PhD in medical education. Aimee, thank you for joining me today.
That's my pleasure. Thank you so much for asking me to be here. I'm absolutely honoured.
Always. So today, to kick off this kind of specialty insight series, we're going to be talking about general surgery, what general surgery is, what a typical day and the training pathway and things for a general surgeon might be like, the different career opportunities that people might have, and Aimee's own experiences working in the field. So, Aimee, I guess the simplest way to start would be for the plebs among us, myself included, what is a general surgeon?
It's quite funny because I think the very traditional meaning of a general surgeon is exactly that, a general surgeon that can do a little bit of everything. And when you thought about a general surgeon many years ago, it would be the person that could do abdominal surgery, the person that could deal with someone going into labour. It would be someone that could do limb trauma. Now, when we think of a general surgeon, it is pretty much an abdominal surgeon. There are certain exceptions to this. So a general surgeon would also do breast surgery, but really general surgery nowadays is split into upper gastrointestinal, which is everything, I suppose, from the mouth to the duodenum, so the bit just after the stomach, or lower gastrointestinal, which is everything from the duodenum down to where food exits the body, as well as breast surgery as well.
Okay. So are you saying then historically, I mean, you were talking about lower limbs and delivering babies and cesarean sections and things like that. So nowadays I guess we have specialists of other disciplines.
Yeah, and so there are many different types of surgery, and so there are separate people that, say, orthopedics might do the arms and the legs. We would have obstetrics and gynecology surgeons, but even within general surgery, it's quite interesting. So I did an upper gastrointestinal, so upper GI firm, and even then there were 3 separate subgroups of people that dealt with either the stomach, the liver, and even those that dealt with the stomach either dealt with the non-cancerous conditions, and then there was a team that dealt with the cancerous conditions. So even within general surgery, there are probably 10, 15 subspecialties, which it's not that general anymore.
Wow. Yeah, I mean that again raises some more questions, which I might ask you about in a minute about those subspecialties. In terms of just in kind of superficial terms, as far as someone who might want to become a surgeon, so let's say we have a student who goes through medical school, is trying to think about what jobs they might want to do, because that's something a lot of people don't appreciate, is that you don't usually pick a specialty until quite some time after medical school.
Yeah.
But someone is now working as a junior doctor and has seen a little bit of everything and decides that surgery might be for them. How would they go about becoming a general surgeon?
Okay, so that sounds very similar to what happened to me. I decided that I wanted to do surgery in the 3rd year of medical school, but my interest had always been emergency, so I didn't know what I wanted to do. I knew I wanted to do surgery, but I didn't know what I wanted to do. So we're quite lucky in that medical schools tend to give us some exposure to different types of surgery, and our placements cover those things. But the thing is, they cover, say, orthopedics in general, but they don't cover more of the subspecialty surgery. So even things like ophthalmology, so eye surgery, or cardiothoracic surgery, so looking at the heart and the lungs, you don't really get exposure to that at medical school. When you finish medical school, you have foundation jobs. So you become a foundation year 1 and a foundation year 2, what we traditionally known as a junior doctor, although now we think of a junior doctor being as anything before a consultant. So in those 2 years, there's the option for placements, and most people do at least one surgical placement on part of those, and they're quite good because it gives people an idea of whether they think they would want to do surgery for the rest of their lives, but it doesn't necessarily give people an idea of what type of surgery they'd like to do. So there's 2 options to help people decide. First of all, after foundation, to become a type of surgeon, you have to do 2 years. Well, for most specialties, you have to do 2 years of core surgical training, which is 2 years where you rotate around different surgical specialties. And for most people, that gives them exposure to different types of surgeries that they wouldn't have considered. So for mine, I did 2 general surgical placements, a urology placement, and a vascular surgery placement. But then for my out of hours, I also covered orthopedics and ear, nose and throat surgery. So it gave me some exposure. And then for the surgical exams, you have to cover all of those specialties, so it gives you an interest. So most people by the end of core surgical training have a really good idea of what they'd like to do before they become a registrar, so they train in one subspecialty of surgery. But even if people aren't ready at that point, they can still, what most people do when they're junior is they just ask certain specialties if they can spend days with them, or just get to know people in certain areas and speak to people, get an idea of what it's like. So normally by the end of core surgical training, people have got an idea of what type of surgery they'd like to do. And for me, I went through a journey of, I really wanted to do vascular surgery, then I really wanted to do orthopedics, but spending time in each of those, it made me realise the things that I did and I didn't like about each specialty, and that helped me come to the decision that general surgery is what I wanted to do.
So you're saying that even if, let's say you were doing those 2 years of common surgical training and you, I don't know, you were interested in urology perhaps, but you didn't have a urology job, you're not then limited to only the jobs in which you've worked. You could ask surgeons to maybe go and spend time observing in urology.
Yeah, so before you become a registrar in one subspecialty, you needed to have done a year in it. So most people have done at least 6 months of that in core surgical training, and then might do another year and add 6 months on, but that's not necessary for everyone. Some people realise midway through that they want to do something completely different, and then we'll do a non-training year in it. But yeah, people quite often spend time in other subspecialties if they're not 100% sure what they want to do.
Amazing. So then it's almost generated 2 questions to get to quickly. The first is that you mentioned some exams.
Yeah.
So the exams don't stop when you leave medical school?
No. It was quite interesting that everyone always said to me when I want to do medicine is, it's a lifelong career, you never stop learning. What I hadn't realised, so I'm 34 now and I've still got lots of exams to go. I'll still be doing exams into my 40s, which is quite interesting and something that I'd never really appreciated. But that said, so once you finish medical school, you then do your specialties exams. So for surgery, it's called the MRCS, so the Member of the Royal College of Surgeons exams. And that's in 2 parts. So there's a written part, which is a multiple choice question exam. And then the second part, which for those of you that know is like an OSCE. And for those of you that don't know, it's almost for those that are doing the MMI interviews, it's quite similar in that you have stations. So it stands for Objective Structured Clinical Examination. And you have all these stations that you go around and each one has a theme. So in some, you might be asked to take a history from a patient, so ask them questions about what's brought them in. Others, they might have a certain presentation. So one, there was a patient with a hernia and I was expected to examine them. In another one, there was an unwell patient. It might even be that you have skills. So one of my stations was that I was working in a tiny hospital and I wanted to convince the consultant of a larger hospital to except one of my patients, and that was a whole station. And those two parts are what make up the first exams. Now, some specialties also have an exit exam, so just before you become a consultant, there are another set of exams, so that's what I'll be having in a few years as well.
So Amy, you said that you had, through all your experiences, you decided the aspects that you liked and some of the things that you weren't so keen on about these different specialties, which does beg the question then, what is it about general surgery that attracted you to making that decision?
So when I joined medical school, I actually joined medical school to do emergency medicine, and that had always been what I'd hoped to do. And it wasn't until a placement. And actually, strange enough, the reason I decided I wanted to do surgery is I had this very kind surgeon say to me at the end of clinic one day, "Don't let being a girl put you off being a surgeon." And I went home and so why would he say that to me? I don't want to be a surgeon. I'm not a surgeon. All surgeons aren't very nice to their patients. And then there was me thinking, well, actually, this surgeon has been nothing but lovely. Every surgeon I met does ward rounds twice a day, has patients come from all over the country. And I was thinking, and you don't like operating. And I'm just thinking, actually, you've really enjoyed being in every single operation. And just literally it hit me that night that was what I wanted to do. And it was almost like this light bulb just made me, I think I've been so close to considering doing it. So then it was then that debate, well, I really wanted to do emergency medicine, but now I want to do general surgery. So I was trying to think about how I could still stay a generalist and go through. So because my interest had been a combination of emergency and trauma, I think I went down the orthopedic route initially because my idea was, well, trauma surgeons. And when you think of trauma and orthopedic, you think of trauma surgeons. But then I realised that even though I like the idea of trauma, I like the idea of abdominal trauma and chest trauma. So that brought me back to that. I also, quite strangely, like the medicine of surgical patients. So I like to spend time with the patients that are on intensive care unit, and I like to go and see the emergencies at A&E and go and see the traumas. So that left me with the debate between vascular surgery and general surgery, because quite traditionally it used to be the vascular surgeons that used to do a lot of the emergency surgery. But then vascular surgery changed only about 5 or 6 years ago, but I knew it was happening in that it used to be vascular surgeons that used to do emergency surgery, but vascular surgery became its own subset of training. And now vascular surgeons only have to do general surgical on-calls until so far into their surgical career. So thinking ahead, I thought if the trauma surgeons and the emergency surgeons and essentially anyone working acutely in future will be those general surgeons. So when I thought about I want a role where I can do both acute and elective surgery, I still want to do something that's quite general. And I really like the medicine of surgical patients. That not only got me to gastrointestinal surgery, but also made me focus more on upper gastrointestinal surgery, because a lot of upper GI surgeons deal both with the chest and with the abdomen. And then that meant that I think that I'll be much more comfortable dealing with all types of emergencies in future, as well as being able to do that elective work as well.
That's really interesting, because again, for the benefit of the boys and girls at home, one of the criticisms that I hear often of modern surgical training is that everyone is a hyper specialist, particularly in maybe not so much orthopedics, but other specialties where, using the example of orthopedics, where, sorry, you can't be seen for 6 months because we're waiting for the right medial malleolus surgeon to have a spot on their list free. Whereas what you're saying is that general surgery, although there are these subspecialties that you identified, maybe hasn't moved so far in that direction.
I think it has for those that want it to. So I work with surgeons that almost entirely do, say, pancreatic surgery or very subspecialized liver surgery. But I think there's a need for both of them, and I think that the easiest specialty to have that both is in general. So my kind of thoughts are, if you have a cancer that only 10 people in the country have, you want the surgeon that's operated on 9 of those. But actually there will always be the need for someone, if someone unwell comes in the middle of the night, there's always that need for someone that can do various emergency surgeries and not just say, no, I'm not doing this because that's not my subspecialty. So for me, there's a need for both. From my point of view, there's a need for both generalists and subspecialists. Now, training is geared slightly more towards a subspecialty, but luckily there are lots of consultant posts in these very general surgical areas, and there is a way that you can gear training up towards general surgery almost as a subspecialty. So you take emergency surgery to be your subspecialty.
Amazing. I mean, I guess there's a parallel there to acute medicine, right? Where we're seeing, I feel like we see less of them now, but you can still almost, your specialty, particularly for the more old school consultants, they are just sort of trained in general medicine and can do a little bit of everything, and often seem to know as much as the specialists about most things. So it's nice that, as you say, there are surgical posts that still reflect that desire if people want to be generalists. I guess maybe then that can lead us into, you know, you've been a surgical registrar, you're a general surgical registrar, and you're trying to decide about the different options that you might have available. So what different sort of career options can someone in general surgery have?
So, as I've mentioned, the 3 main areas within general surgery are breast surgery, upper gastrointestinal and lower gastrointestinal. For breast surgery, I must admit I've not done too much breast surgery. I've only done it in a very small hospital. But for breast surgery, most become cancer surgeons, but some will do either benign or even cosmetic, and might do a small amount of cosmetic on the side. But keep in mind that when I talk about cosmetic, it isn't necessarily people getting their boobs to be bigger. It can be all sorts of cosmetic. It can be breast reduction because of, say, bad backs, or reconstruction following cancer, things like that. So some people work in those areas. Within upper gastrointestinal, it's generally split into liver and pancreatic surgeons, benign surgeons, so the surgeons that don't deal with cancer, so they might deal with things like acid reflux or weight loss surgeries, or even gallbladder surgery, so taking out people's gallbladders. And then there tends to be the cancer-based surgeons who deal with things like that deal with either esophageal or stomach cancer. For lower GI surgeons, once again, you tend to split it into specialist teams. There might be cancer-based surgeons, and then a lot of times there are surgeons that do things related to bowel disorders, so normally inflammatory bowel diseases, so things like your Crohn's and your ulcerative colitis, and you have surgeons that are very specialised, things like that. Within each of those, all of the surgeons will have day case lists, and in their day case surgery they might deal with very minor procedures as well as doing all of their subspecialty things. So each of them might do hernias, say lower GI might do things like hemorrhoid surgeries, and upper GI might do gallbladder surgeries. So even though they have the big cases that they do, actually most of the time, most consultant surgeons will only do one very big case per week, but then we'll have 2 sessions where they do smaller surgeries as well. So normally spend 2 days operating, 1 large session and 2 small sessions, but it's their 1 session that they subspecialise, but then they see all of those people in clinics as well.
The last thing I want to ask about this kind of domain is just you're a surgical registrar. What is a typical day for Ms Charnell on you go to work, you go to the hospital, what do you actually do?
So it depends on whether I'm on an elective week. So elective means a standard day, or whether if I'm on an acute or an on-call week. So my elective weeks tend to be Monday to Friday. My hours are typically, there should be 8 till 5. Now, if I'm not covering the wards that week, it might not be too bad. I get in just before 8 o'clock, consent the patients, go to theatre, might do the same in the afternoon or a full day case. Or if I've got clinic, I go to clinic and then do whatever I'm doing in the afternoon, endoscopy, clinic, or even I might do a theatre list for half of the day. If I'm on a ward week, that means that I've got to do all of my jobs as well as cover the ward. So they come round once every, say, 8 weeks or so. And then for that week, I will get in, say, 6 o'clock in the morning and see the ICU patients. I then go 7 o'clock in the morning to consent all of the patients for surgery. I do the ward round between 8 and 9 in the morning, because the juniors, the F1s, don't start until 8, and it's not very fair me asking them to come in any earlier because I've got a long day. So the junior doctors come in at 8, so I do my ward rounds between 8 and 9. I then operate or do whatever my standard day would be for that day, and then I also do a ward round in the evening. So there's one doctor whose job it is to do the ward round each evening, so only one doctor stays late, and then I normally finish about 7. So even though my hours are typically 8 till 5, I might do, say, 6 till 7 or 8 those days, but the rest of the time it's not too bad. If I'm on a theatre week, if I'm in theatre, it will always be the job of the registrar to go through the consent with the patients. In terms of ward round, it's normally the registrar that does the ward round most days, but the consultants will come on at various points to see their patients, and then it's my job to know what's happening and what the decisions made by the consultants are. So sometimes it might be that they come round on the morning with me, but other times it might just be that they pop on in between things. If I've got clinics, the junior registrars tend to see the new patients, so it's my job to see the patients that have been referred via the GP, either with the plan for an operation or what's called a 2-week wait clinic list. And a 2-week wait clinic is where there's a suspected cancer. So it's my job to see those patients, to take a full history and to examine them, and to decide what investigations they need next or whether they're suitable for surgery. But there's always a consultant that I can discuss those things with. But I might have other things as well. It's not just operating in clinics. We have a multidisciplinary team meeting once a week. For us, that's a Friday morning. And it might be that we talk about all of the new cases that we've seen that week as a big team. And they have all of the upper GI consultants there, plus all the specialist nurses. We have a radiologist who goes through all of the x-rays and the CT scans of the patient. We have a histopathologist that talks about any of the specimens we've sent and what they can see, as well as having things like oncologists and general medics there. So it's a really big team meeting that we have once a week. And then on top of that, we might have things like teaching for the juniors, and what we call M&M meetings, so mortality and morbidity meetings, so where we talk about cases that haven't gone quite as we'd expected and what we could have done as a team. So my weeks tend to be really, really varied, even when I'm not on call. I can do. So the weeks broke up into mornings and afternoons, and in those 10 sessions of the 5 days, I can easily have done 10 different things. So it's really varied. When I'm on call, the days are 13 hours, so start at 8 in the morning, finish 9 at night. Because I'm on the junior registrar rota, we don't do nights by ourselves on these rotas, but sometimes we get asked to go in and cover some nights. With those, my job is to cover the A&E admissions, the GP admissions, and then to do certain operations. And then the senior registrar covers the ward rounds and the operating and inpatient referrals. So my typical day on an on-call day is that we have handover in the morning, and we have handover as a full team, the junior registrar, the senior registrar and the consultant, as well as all of the juniors as well. Depending on what specialties you're on, sometimes the nurses come into those as well, or at least a nurse representative comes in to talk about them. The senior registrar goes off and does the ward round, and then I see the referrals that we've been missing from overnight. And then most of my day then is between seeing A&E patients, running up to the ward, see the GP patients and back down. And if I get a 5-minute lunch break in those days, it's a very, very good day. And those days, and even when I get a lunch break, it's normally quickly sitting and writing all the new admissions on the computer. So they could be really, really busy. During those, I might not do very big surgeries, but I will do things like appendectomies. And if someone comes in with an abscess, I'll do those in between seeing the patients in A&E. The great thing is when I'm covering A&E is it also means I cover the traumas. So because I work in a regional centre, any traumas that come in, either adult or child, I cover both adult and child traumas. We have a general surgeon there, an orthopaedic surgeon there, as well as the A&E doctors. We always have an anaesthetist there and a trauma manager. In some places you might have teams like the neurosurgical team down there, but they're the main ones. So I go down and assess the patient from a surgical point of view to see if they're safe or they need any input. And the amazing thing about traumas is sometimes because the ambulance team will call about 10 minutes ahead, and sometimes you expect this very, very well patient to come in, and all of a sudden they could come in very, very poorly because something's changed in that 10 minutes and they haven't had chance to call you. Or you can be all ready to go thinking that someone's really sick. And so, for example, I was told that someone had been stabbed in the chest the once, so we were all ready to open up the chest, and actually it was the bottom that they'd been stabbed in. So actually that just completely changes who you need, what you need, whether that can be done in theatre or in A&E. And that's, for me, that's it can be a horrible thing, but that's my adrenaline rush of the day, because I never know what I'm expecting, and then 10 minutes later I'm putting in a chest drain or getting this patient up to theatre. So that can be really varied and means that I've got to be very much on my toes all day.
Amazing. I mean, you've just given like a really, really good stuff that I'm in my final year of medical school. I didn't appreciate quite how varied that would be. I've remembered what I was going to ask you earlier, which is and this is building on what you said about you've experienced lots of different specialties and decided the elements that you were fond of and not fond of. What are the personality traits, or basically what would make someone, do you think, suitable for a career in surgery? If you like X, Y, and Z, then you should think about surgery.
Yeah, so I think traditionally we thought personality traits as being that very masculine figure, that type A personality in surgery. And when you think of an old school surgeon, you think of a old, rich white man that has lots of authority. I think there are certain elements that so I went to a meeting where the old head of the Royal College of Surgeons came and said that we need to move surgeons away from being traditionally these people with type A personalities. I've got a type A personality. I mean, I'm not a rich old white man, but I do have a type A personality. I think it's helped me do surgery in that I'm very willing to fight my ground for patients. So it's been very helpful for me because, for example, I needed a consultant to come down because we got a really sick patient once, and she refused to come down, saying he doesn't need an operation. And I said to her, I have seen this patient, he is dying. If you refuse to come down, this patient will die and it will be your fault. So I was willing to stand up to her to do that, and she'd come down, she took him to theatre, and that's a kind of quite ballsy and perhaps quite a silly move to make, but to me that was important to do. But that said, that doesn't mean that you need that trait, because because me also be having that kind of personality trait means that 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 I mean, as well as fighting the battles for surgery, it means that it's quite hard to relax when I'm on a shift. So actually, some of the people with the type B personalities tend to find their shifts much easier and much calmer, because there's just that way of that, just that calmness, even with the acuteness. So, I mean, keep in mind that the reason I didn't do surgery initially was because all surgeons were horrible, and that was this trait that I had. I think what I would say is your personality type doesn't matter, and this is what I realise more and more. There are certainly personality types that are being attracted into surgery, and like that think that they want to do surgery, but actually quite often a lot of the best surgeons I know are ones that don't match that personality type.
Sure.
What you need to do is you need to know that your training will be long, your training will be hard, and you need to have a lot of dexterity and really enjoy operating. You need to enjoy the medicine. What I would say is, if you have a passion not only for operating, because just to enjoy operating could be quite dangerous, because as I say, keep in mind that most surgeons will only operate 1 or 2 days a week. If you like that varied role that is a combination of operating, seeing sick patients, going to clinics, say doing endoscopy lists and day case lists, then really it doesn't matter what type of personality you are, you will make it work. You need to be an advocate for your patients and your colleagues, and also for yourself sometimes. You also need to be an advocate for yourself. And as long as you can do that, you could be the quietest person, you could be an absolute introvert. It genuinely doesn't matter, as long as if you want to do surgery, then it doesn't matter what your personality is.
Amazing. And then the last thing, although I realize that it could be a fairly chunky discussion, is we're very lucky to have you on because you come from a quasi-military background. Oh, not quasi is unfair, a strong military background. And that, I think, is not all specialties will be amenable to that, but general surgery probably is one of the biggest ones. So a question that we had sent in was, did you yourself either attend medical school via the military with the support of the military, or did you get involved afterwards?
Yeah, so I'm a Army reservist, and I've been in the Army Reserves for 10 years in a medical corps. And I did have that debate of, do I join full time or do I stay as a reservist? For me, I really wanted to stay as a reservist because, to me, the surgery came first, and to me that was really important, because you're right, some subspecialties and subspecialties can be hard to do in the military. None are impossible, but some can be harder because they have even less numbers going into certain, so for example, they will only have so many general surgical places, which are much less than with national recruitment, and the same with orthopedics. So it's even harder to do your specialty in the military than it is anyway, which some of these can be quite competitive. For me, it was never, I must admit, I talked to my mom and said that I was thinking of joining the military full time, and I wasn't sure whether to go through a scholarship. I had 3 jobs at medical school, so the scholarship would have been lots. But my mum said to me, she said, Amy, you don't know whether you're going to want to have 6 kids in 5 years, and if you do, would it really be a good job joining in the military? And even though I didn't think I'd quite want 6 children in 5 years, I think the point was there is that I didn't know what I would want to do in a few years.
Yeah.
So for me, being a reservist gave me the best of both worlds, and it meant that I could do both. Quite a lot of my colleagues joined full time, went through the scholarship, and I've not known a single one of them regret it. But either way, you could do the various specialties. So, for example, there are lots of people going in specialties that you wouldn't expect in the military. So we're having more obs and gynae doctors, more paediatricians, things you wouldn't necessarily expect. And I think the great thing is we're the ones that are going through and shaping how things are becoming in the future.
amazing. And I mean, just to, I realize, as we discussed before, there are obviously certain things that we can't talk about due to the nature of this, but all I want to roughly get at is that the day-to-day job that you may be spending in a hospital, working as a surgical registrar, is that very different to working in a military hospital, for example?
Well, it depends on what role you have in the military as a reservist. So I'm speaking as a reservist. So there are different roles you can have even as a reservist. So when I've gone out as a reservist, I've gone out almost in a GP role. Other times you can go out very much as a surgeon and only doing certain types of surgery. I think when you imagine anyone going out in anything that's not their normal NHS hospital, so for example, one of my colleagues went out and she was working with some researchers on a boat for multiple months. Whenever you go out and you're doing things away from your NHS practice, you will always work with a different demographic, whether that be you working with a different age, whether that be that you're working with different populations. You're working with different constraints. As anyone that's ever worked in surgery knows, that the answer to everything is get a CT and get a CT scan. And obviously when you're in the middle of nowhere, that's very, very difficult to do sometimes. So you're working, you might be seeing the same things, but you might be having to have different considerations. But overall, I am a surgical registrar in the NHS and I'm a surgical registrar in the military. And it's quite nice in that as a reservist, the hospital give me extra time off to go away and do these things. So even if they are different and even if they're the same, I think that they complement each other really well, which to me is the most important thing. Even when I've been away for months with the military, I still feel that there's things that I've used from my NHS post, and no matter what I do, there are always things that I bring back to the NHS and vice versa. So I think that they sometimes can be a bit different, but they're complementary, which is the most important thing.
Fantastic. And that, I think, is as good a place to leave it, apart from one final question.
Yeah, of course.
Which I think I'd get in a lot of trouble if I didn't ask, which would simply be, do you have a piece of golden advice for aspiring general surgeons?
Ooh, I think start the journey early. So if it's something you want to do, try and spend time with surgeons. Try and there are so surgical conferences are very typically cheap or even free for medical students to go to. So consider it. But on the other hand, don't close yourself up too early. I found that quite often the surgeons that can be quite perhaps arrogant are those that go through medical school and go through being a junior doctor as well. I don't care about learning this because I want to be a surgeon and I know I'm going to be a surgeon. So what I would say is try early on to speak to people, go to things, but also to keep your mind open. Even if it's 100% sure what you want to do, that doesn't mean that you won't learn anything else from other placements. I had three surgical jobs in my foundation years, yet the job that I took most away from was my elderly medicine job, because I didn't necessarily need to write lots of discharge summaries in surgery to make me a good core trainee, but actually dealing with an unwell elderly person and being competent to do that is something that is incredibly useful even now, and is something that I find really helpful every day.
Fantastic. Well, that's where we will leave it. Thank you again so much, Amy, for coming on and being the inaugural speaker in this series.
That is my pleasure. Thank you again.
Not a problem. Are you happy for people to contact you if they have any queries?
Please do. So I'm on Twitter. So it's Aimee Charnell, and it's spelled quite strange. It's AIMEE Charnell, CHARNELL. If anyone wants to contact me by email, it's just that name with a dot in the middle, and that's at doctors.org.uk. And I will be really happy for anyone to contact me by Twitter, by email, with any questions at all that you have.
Awesome. We'll make sure that they'll be overlaid on the video and linked in the video description as well,
Great.
so you can access those easily. Thank you very much, Amy, and we'll leave it there. Take care.
That's my pleasure. Thank you again.